Well, hello again, everybody. Welcome to part two or lecture two of the 4 lectures on disorders of the cardiovascular system. So, in lecture one, really, we just kind of did an overview of some of the components of the cardiovascular system. We talked a little bit about things that can go wrong with the arteries and the veins. We talked a little bit about hypertension. I introduced different tests or imaging modalities that can be used to assess the health of the cardiovascular system. And so where we're going to turn sort of the corner now and focus our attention is really on the heart of this topic, which is what happens when there are alterations in cardiac function. So we're going to take essentially we're going to be focusing on the heart, and we're going to be looking at the various pathologies that can result from a disruption in different components of the heart. We're going to start off with heart failure, and that may seem a bit strange. It may seem like we're jumping to the end before we've covered the beginning. But I start off with heart failure because a lot of the following or the subsequent pathologies that we're going to discuss can have as an end result heart failure. And so we start off with heart failure, and that's going to sort of set us up for looking at the 4 components of the heart that actually helps it to pump blood. So we're going to see what happens when there's disease of the vessels that supply the heart with blood. This image that you're seeing here, we see the major arteries of the heart. And so what we're going to be asking ourselves is what happens if there's an interruption of blood flow to specifically the myocardium, which is the muscle that pumps or that contracts to generate the force to force blood out of the heart. Then we are going to look at what happens when the valves don't work as they should. From there, we're going to actually turn our attention to looking at some diseases of the heart muscle itself. So we're going to talk about things like myocarditis and cardiomyopathy. And then fourthly, as the 4th component of this group here, we're going to look at what happens when there's an interruption or when there's a defect in the electrical conduction system. So the electrical conduction system, you would have learned in ANP 1105, is called the intrinsic conduction system. And it's the series of electrical events that ultimately leads to the contractile events of the heart that allows the heart to pump blood. So this is where we're going to be going for most of the rest of this topic. Then we're going to learn a little bit about congenital heart diseases or disorders. And so those are things that you're born with, defects. Really, they're mainly structural defects that we're going to be addressing, and how that affects the ability of the heart to do its job. And finally, we're going to wrap up this topic by discussing different types of shock. So that's where we're going. So just hang on. I'm going to set a foundation, and then we're going to move right into the various subtopics. Okay, so just a very brief review. I'm not going to go over the way blood moves through the heart. You've got the basic circuit here. So you've got pulmonary circulation, you've got systemic circulation, and then sitting in the middle or in between the two or bridging the two, so to speak, is the heart. What you've got down here are the various valves that have been labeled, so I'm not going to go through that. This should be reviewed for you. But I want to set the foundation by reminding you that the heart is made up of 2 connected side-by-side pumps. All right, so keep that idea in mind. What does a pump do? All right, a pump uses some sort of force, and it tends to move a liquid or a gas, for example, from one location to another. So if that's what the pump does, the question that we next ask is what happens when the pump fails? So when the pump fails, its ability to move that liquid is going to be compromised, right? So keep that in mind. That's the first concept that I want you to keep in mind. We've got a right pump, we've got a left pump. The second thing that you have to or that you should be keeping in mind as we make our way through this topic is that your cardiovascular system is a closed circuit, right? So I want you to think of it as a closed circuit. You've got this circuit. If you can think of a circle, and then on opposite sides of this circle, you have two pumps. And those pumps contract simultaneously. And when they contract, they keep pushing the blood forward and just moving it around. The fact that the circuit is closed, right, means that those pumps have to work together to maintain the proper movement of blood. So now if you want to sort of think in your mind's eyes, so we've got this sort of circle, we've got these two pumps. So ask yourself, what would happen if one of those pumps fail? Right? And that's what we're going to be looking at as we jump into heart failure as a foundation for the rest of this particular topic, right? What happens when one or both of those pumps fail, given that it's a closed circuit? And so that really is just what heart failure is about. I start off with this definition that I took from, there's actually a journal of cardiac failure. That was published, this quote that was published in 2021, and it nicely summarizes what happens in heart failure, right? It's described as a clinical syndrome. A syndrome is simply a collection of signs and symptoms, right? It can be caused by a structural or a functional cardiac abnormality. Structural, what happens if the wall, right, for example, doesn't contract as it should. Functional, what happens if the intrinsic conduction system doesn't work as it should, right? So we've got a structural or functional abnormality, and what accompanies those abnormalities are elevated natriuretic peptides. So you probably, or you should have been introduced to ANP and BNP in ANP 1105. And these are two peptides that are secreted by the heart to promote the excretion of sodium and by extension water from the kidney. So really they work to try to lower the blood volume, and in lowering the blood volume, they can lower the pressure on the heart. And we'll come back to that. So we've got elevated peptides, and the other thing that we will see in heart failure is congestion, right? You would either have congestion in the pulmonary circulation or in the systemic circulation. And so those are just some of the sort of cardinal signs and symptoms of heart failure. I've put this in here to sort of help you to track the progression of this pathology, so you can be at risk because of structural changes. You can have structural changes without symptoms. In that case, you're in the pre-heart failure stage. Then when you've got symptoms, things like fatigue and shortness of breath, you're in heart failure, right? And then you can have advanced heart failure. Advanced heart failure is when you become a candidate for a heart transplant because the normal interventions don't no longer have an effect. So I've said here also that heart failure happens when the heart can no longer function. What is the job of the heart? Really is to generate adequate cardiac output. And if it can't do that, then your tissues are underperfused, and in effect, the heart is not doing its function, right? Sometimes there is increased diastolic filling pressure of the left ventricle, in addition to a cardiac output failure. And sometimes there's increased pressure in the pulmonary circulation, and we will come back to these, and we will see the pathophysiological basis for these signs and symptoms. You may oftentimes hear heart failure being referred to as congestive heart failure, and that usually means that there's a fluid overload either in the pulmonary circulation or systemic circulation. And again, we will come back and see why this is so. We're in chapter 19 for those of you that are in the text. So the next couple of slides, we're going to look at what happens when the left side of the heart fails. And then we're going to turn our attention and see how the right side of the heart fails. And as I'm going through this, I hope you get the picture that failure of one side of the heart will eventually lead to the other side failing, because again, it's this side-by-side pump in this closed circuit. So to introduce you to left-sided heart failure, let's consider a patient who gets short of breath with activity. So whether they're walking a long distance or whether they're exercising, there's shortness of breath. Shortness of breath is known as dyspnea, right? And so the question becomes, right, how could a patient with shortness of breath, how could that sign and symptoms be related to what's happening with the heart? Because if you think about shortness of breath, what immediately may come to mind is that the lungs is the problem, right? The patient may have some sort of pulmonary disease, and you will be doing the respiratory system coming up shortly, right? But a person can have shortness of breath and it can be indirectly related, right? And that can indirectly related to the lungs. And in this case, we can have cardiac disease that can lead to shortness of breath. So the guiding question for this particular part of the discussion is how can cardiac disease affect the lungs? So let's come back and see what happens if the left ventricle in this instance fails. So we've got left-sided heart failure. The left ventricle is not pumping. So what we have is a decrease in blood flow from the left heart to the rest of the body. Remember, this is a closed circuit. So you have to ask yourself the question, right? What happens if this left pump is no longer participating in this closed circuit? What happens to the blood flow? What happens to the other pump that's involved in this closed circuit? So to answer those questions, think about where the blood entering the left ventricle is coming from. That is blood that's flowing from pulmonary circulation. So again, if you were to think about blood flow in the circulatory system, we've got systemic blood flow going back to the right atria via the superior and inferior vena cava, from the right atria into the right ventricle, from the right ventricle out through the pulmonary artery into pulmonary circulation. From pulmonary circulation, we've got the right and left pulmonary veins, bringing it back to the left atrium, from the left atrium into the left ventricle, from the left ventricle out through the aorta. So if this part of the circuit is not holding up its end of the bargain and it's not pumping blood effectively, what's going to happen is that the incoming blood, and so that's blood from pulmonary circulation, is going to start to back up, right? And as it starts to back up, where is it going to back up? It's going to back up within the pulmonary circulation. And so that is going to lead to what is known as pulmonary edema. Pulmonary edema is going to result in an increase in the pulmonary pressure. As that pulmonary edema / pulmonary pressure starts to rise, blood is going to be forced out of the pulmonary capillaries and into the interstitial space. It's a closed circuit, right? So you can't take some of this blood and park it somewhere else and say, okay, we're going to wait until the left ventricle starts to function again and bring it back in, right? So it's going to back up somewhere, right? And it's the forcing of the blood out of the pulmonary capillaries into the interstitial space, which is going to cause your shortness of breath, which is the dyspnea that we started this whole discussion with, right? And congestive heart failure, or CHF, comes from the fact that with left-sided heart failure, there's congestion in the lung, right? And that congestion is caused by the backup of the blood in the lungs because it's not being moved forward by the failing left heart. One of the ways you can hear, or you can know, or you can detect this backup is that you can listen to the base of the lung, and usually there will be cackles or these noises. If you listen with a stethoscope as that blood is starting to back up, you will hear what are called cackles in the base of the lung, right? And as that fluid starts to build up, the more fluid there is, the higher up these cackles, so to speak, can be heard. So you've got pulmonary hypertension because of a backup of the incoming blood into pulmonary circulation. So what does that do for the right side of the heart, because we're in this closed circuit? So when we get back up in the left failure of the left side, that can precipitate right-sided heart failure. Why? Right? Remember, your left side is sort of the strong, robust side. And so the walls of the ventricles are thicker. It's forcing blood because it has to generate more force into the entire systemic circuit. The right side really only has to sort of push the blood laterally almost into the lungs. So the walls are not as thick. Once the blood starts to back up because of left-sided heart failure, then it increases the work that the right pump needs to do. And the right ventricle is not as strong as the left because the walls are thinner, right? So the increased pulmonary hypertension means the thinner walls of the right ventricle, they have to generate more force to overcome this increased pressure and force the incoming blood from systemic circulation into a pulmonary circulation, right? So that increases the workload of the right ventricle, right? And if this increased workload, so if we don't intervene to help the left side of the heart, the increased workload over time will cause the right heart to fail. And when the right heart fails, we're going to see the same thing as we saw for the left-sided heart failure. What do I mean by that? We're going to have backup somewhere, right? Where is that backup is going to happen? You have to think about where the blood is coming from that is going into the right side of the heart. It's coming from the inferior and superior vena cava, right? So the blood is going to back up initially into those two huge veins. But what leads into those veins, the jugular vein, leads directly into the superior vena cava. And so after a while, you're going to see increased venous pressure or jugular vein distension as the blood starts to back up and back up and back up, simply because the jugular veins have a straight path to the superior vena cava, right? On the other side of this, right, we are going to see backup in areas of systemic circulation. And that backup can reach the liver, it can reach the abdomen. The abdomen, you can see things like ascites. Ascites is just fluid backing up in your abdominal cavity. And the rest of the body, in the extremities, you can start to see edema as the blood starts to pool and back up within your peripheral circulation. And so in this case, right, in this case, you've got what is known as peripheral congestion. You had pulmonary congestion with the left side. You've got peripheral congestion with the right side. And so when you look, for example, you examine someone physically that you suspect of having right side heart failure, what are you going to see? You're going to see jugular vein distension. You might see an extended abdomen. You might see hepatomegaly, which is just an enlarged liver. You might see their extremities, their swollen legs and swollen ankles. And that is simply because the blood is backing up. And so hopefully in those two slides, I help you understand how one side, the failure of one side, can actually lead to the failure of the other side. So we talked so far about the failing heart, whether it's the right pump or the left pump, leading to a backing up of blood either in the pulmonary or systemic circulation. But the other thing a failing heart has trouble doing is maintaining forward flow. So here we're looking at what happens if the left heart fails. We've got an increase in the backup of flow, pulmonary congestion, there's increased work for the right heart. The right heart leads to failure, right-sided failure that leads to backup of flow within systemic circulation. Pulmonary circulation, we talked, for example, about what shortness of breath or what causes shortness of breath. The other thing we see with left-sided heart failure as a result of pulmonary congestion is orthopnea, right? And the best way to describe orthopnea is think of the classic story that a patient that comes in, right? And they report getting very short of breath upon lying down. Why, right? That condition is known as orthopnea. And why, right? Because gravity is no longer working when you're lying down. Gravity is no longer working to cause the blood to pool in the lower extremities. And so blood can make its way back to the heart more easily, increasing the heart the heart work rate, or the amount of work the heart has to do. And so oftentimes these patients will sleep with their heads held high on many pillows to help prevent the pooling of blood in the lungs. Paroxysmal nocturnal dyspnea is another sign of pulmonary congestion that really is just shortness of breath during sleep, and it tends to come on very suddenly, and usually the patient is startled and they have to wake up every couple of hours and move themselves into an upright position. All right, and that's the same idea with orthopnea, where you've got a lack of gravity causing the blood to pool lower, and so it pools within the lungs. That's another sign. Bendopnea. Bendopnea simply means shortness of breath when bending forward, right? Bending forward increases venous return to the heart, and so that failing heart may not be able to handle it, causing again a backup of flow into the lungs. So these are the signs and symptoms of the backwards effect of heart failure. What about the forward effect? So let's just think of the left side of the heart. What does the left side of the heart do? It generates cardiac output to provide the oxygenated blood that the body needs for its metabolic purposes, right? And so what happens if that side of the heart fails? Fatigue and weakness because of a decreased blood flow to the rest of the body. Your extremities may be cool, decreased blood flow to the limb, because remember, it brings heat. It brings oxygenated blood to drive your metabolic reactions, and one of the byproducts of those reactions is heat. And so if that metabolic reaction slows right down, then the rate of heat generation slows down, and you may feel that in your extremities. Decreased blood flow to the kidney, that's going to lead to oliguria, which is a decreased output of urine. And then you have things like dizziness, syncope, which is fainting, an altered mental state that simply becomes results from a decrease in blood flow to the brain, right? So that's the problem. Right? So what I want you to keep in mind, there are forward effects of the heart failing, and there are backwards effects. The backward effects usually has to do with piling up, right? But the inability to maintain forward flow is also a problem. Right? And so that's heart failure. And as we move forward, when we start to talk about diseases of the vasculature or cardiomyopathies, you will see that those diseases can also precipitate heart failure, because you're going to see some of these same signs and symptoms being manifested in those diseases. All right, so let's move along. How do we diagnose heart failure? I'm just going to touch on this very lightly. There's no single test, but it's just an accumulation of signs and symptoms, and there are different criteria that are used. I've stuck one in here, right? So you've got major criteria and minor criteria, which is just a collection of signs and symptoms that are associated with heart failure, right? And so usually the standard is you can have one major plus two minor, all right, or two majors and one minor criteria to make the diagnosis of heart failure. But these are just some of the commonly used criteria. I've discussed those. S3 heart sounds I haven't talked about. That's just an extra heart sound that's heard, right? So we talked about S1, which is closure of the AV valves, S2, which is closure of the SL valves. If you don't know what that means, I'm going to encourage you to go back and review the heart physiology from 1105. When you have heart failure, you may have extra heart sounds. Some textbooks will mention S3 and S4. They're mainly more for cardiologists, and it's more in allowing them to sort of narrow down the type of heart failure. But you may hear abnormal heart sounds, tachycardia, which is just an increased heart rate as the heart tries to compensate, right? Your body is sending the heart, we're not getting enough blood, do something. And in response to that, the heart says, okay, what can I do? I can just increase the rate at which I am beating. So those are just some of the commonly used criteria. In terms of imaging modality and what you see, Chest X-rays, you might see cardiomegaly, which is just an increase in the size of the heart as it tries to compensate for that. And if it has to do more work, it might increase in size. Pleural effusion, we'll talk about pleural effusion. This is just accumulation of fluid within the pericardium. An echocardiogram, an echo, what you might see an echo, you might use it to measure ejection fraction, which we'll talk about on the next slide. You might see chamber size, you might look at the valve. This is a really useful and informative is the word I was looking for, a tool. It's non-invasive, easy to do, and it gives you a ton. It can give a cardiologist a ton of information about what's happening with the heart. So an echo, and it's almost as easy as an ECG, because if someone presents, they will hook them up to an ECG and immediately they can get a ton of information. An echo is almost as easy to do as an ECG, right? And then you have to take into consideration the past medical history, whether or not there's an illness that may be affecting the ability of the heart to do its job, as well as these diagnostic investigations. In terms of classifying heart failure, right? The ways in which it's classified, it may be classified as right-sided heart failure, or left-sided heart failure, or biventricular heart failure, which is problematic because it means both ventricle. Well, any heart failure is problematic, right? The other way heart failure is characterized is based on the ability of the heart to eject blood from the ventricles, right? Or to relax and fill during diastole. And this is where the concept of ejection fraction comes in. Right? So the ejection fraction, and I've asked the question here, what is the ejection fraction? And if we were in person, I would throw this out to you guys and said, who remembers what the definition of the ejection fraction is? Because sometimes students confuse the ejection fraction with the stroke volume. They are related, but they're two different concepts. The stroke volume is an absolute number, 60 mils, 70 mils, right? The ejection fraction is relative, it's a percentage, right? And so a very general definition of the ejection fraction, right, is the percentage of the total end diastolic volume that's ejected every time, and it's usually in relation to the left ventricle, every time the left ventricle experiences a systolic event. So with every heartbeat, right? So really, to calculate the ejection fraction, right, you take the stroke volume, that's the volume that was ejected, and you divide it by the end diastolic volume. And that gives you the percentage of blood that has been ejected. And that's what's known as your ejection fraction, right? So patients with symptoms of heart failure, right, sometimes are categorized based on whether or not their ejection fraction has been preserved. And again, don't think of it as stroke volume. Think of it as how much or what percentage of that end diastolic volume is being ejected. So they're categorized as either having reduced or preserved ejection fraction heart failure, right? So with preserved, EF is ejection fraction, HF is heart failure, right? The patients have the signs and symptoms of heart failure. So you suspect the patient has sort of a differential diagnosis of heart failure, but their ejection fraction is above 50%, because the normal range is between, I say 50, 55 to 80%, right? And so what you see here, right, is their ejection fraction is preserved, right? So it means that they're pumping out the requisite amount of, or the requisite percentage of their end diastolic volume. But sometimes the problem is that they don't fill sufficiently during diastole. Right? And so heart failure that results from coronary artery disease or HDN is hypertension are two of the main causes of heart failure with preserved ejection fraction, right? We're going to come back to coronary artery disease. I think we jump into that next. A patient with heart failure might be also classified as having reduced ejection fraction. What determines your ejection fraction, right, is your ability to is the heart's ability to contract effectively. So usually these patients have less than 40% in terms of their ejection fraction, and this is a problem with systolic heart failure, and that can lead to decreased cardiac output. That's CO. And usually myocardial infarction, that's what the MI stands for, is the common cause of reduced ejection fraction heart failure. So we've got preserved versus reduced. And I mentioned this as just one of the ways in which patients are characterized, patients that are suspected of having a heart failure. Okay, I'm just going to briefly mention some compensatory mechanisms. And these are all geared to help maintain cardiac output in the early stages of heart failure, because the heart, just think about what the heart is trying to do all the time, just to maintain enough or to pump out enough blood so that your systemic tissues are getting the oxygenated blood they need to perform their metabolic functions. Right? So once the heart starts to fail, there are a number of mechanisms that kick in to try to help the heart to maintain this cardiac output, adequate cardiac output. But these mechanisms, right, contribute to the sort of the failing heart. It contributes to the failing heart actually ending up in complete heart failure. That was kind of a mouthful. In the short term, they're helpful, is what I should have said. But in the long term, they really don't help the heart. They eventually lead to complete and total heart failure. So what are some of these mechanisms? We see heart failure here. We've got baroreceptors. We've got the RAS system. And we've got increased ventricular tension, right? So baroreceptors, where are the baroreceptors? Those are the ones that senses blood pressure. As the heart fails, the cardiac output is going to decrease. That means your systemic blood pressure is going to decrease. That's going to activate your sympathetic nervous system. What is your sympathetic nervous system going to do? It's going to increase your heart rate. It's going to increase contractility. It's also going to help to regulate your vascular tone. It might, and so that'll work together to help increase your cardiac output. That is going to be coupled with what your kidneys can do. What can your kidneys can do, right? Low filtration, right? That's going to lead to increased salt and water retention. That can lead to an increase in fluid volume, which increases your preload. The more preload you have, the better chance you have of increasing your cardiac output. And so that can also help maintain cardiac output. The other thing your RAS system can do is that can also contribute to vasoconstriction, right? To help raise blood pressure. And then you can have increased tension in the ventricular wall. Eventually that leads to myocyte growth. So just the cardiomyocytes just increasing in size to try to compensate and to increase their work performance. The problem with that is that over time, while in the short term the hypertrophy helps to maintain cardiac output, eventually it undergoes what is called remodeling. That simply means it loses its ability to contract. It just becomes overworked. Is one of the ways of thinking of it, right? And it undergoes these fibrous changes, and rather than becoming more efficient at generating force, it just kind of stiffens and peters out. And so you get the opposite outcome of what you would desire to happen. So these all work together to increase, whether it's the heart rate and contractility, whether it's the preload, or whether the strength of contraction in the short term to increase cardiac output. But if an intervention doesn't happen, that can lead to complete heart failure. All right, so how do we treat heart failure? To understand, and I know this is not a pharmacology course, but to understand the treatment of heart failure, you have to think about what the two most common problems that are caused by heart failure. What are the two most common problems, right? Essentially, the job of the heart is to pump the preload against the afterload. What's the preload? The end diastolic volume. What's the afterload? That's the tension or the pressure that it has to overcome, particularly with the left side, to force those valves open to expel, right? Or to eject the blood. When the heart fails, we've got a problem with backup, congestion, either in the pulmonary circulation or systemic circulation. And we've got a problem with a decreased forward flow, right? And so what do we want to do? We want to increase the forward flow, right? So we want to increase our cardiac output when we talk about the left side of the heart. And we want to decrease the backup. We want to decrease the congestion. So that really is the sort of big overriding idea behind the treatment of heart failure. And so this is just a little schematic that very briefly outlines what's going on, right? So if you want to decrease preload and afterload, you're trying to decrease the workload on the heart. And you use things like nitrates to dilate the veins. You might use diuretics to try to decrease your blood volume. You might use other ACE inhibitors to try to dilate the arteries. And so you're decreasing the preload and you're decreasing the afterload, trying to reduce the workload of the heart to help with that backup. Or on the other hand, right, you might want to use things like inotropes, which increases the force of contraction, or beta blockers, right, to decrease the rate of contraction, to increase the heartbeat. So you might be saying to yourself, right, how does decreasing the rate of contraction lead to an increase in cardiac output? Think about what happens when the heart is in diastole, it's filling. Right? So if you decrease the rate of contraction, you have a longer time for filling to come in. You've got a bigger end diastolic volume. And so when you contract, your stroke volume or your ejection fraction increases. Right? And so this really is just, and I know I'm sort of skipping over it quite lightly, but those are your two guiding principles when it comes to heart failure. What are you trying to mitigate? The next two slides I'm not going to go over. They're taken directly from your book, as I said here, and it just summarizes what we've discussed in the previous slides. What happens with left-sided heart failure? What are the backwards effects? What are the forward effects? And what are the compensatory mechanisms? We've talked about all of the various signs and symptoms that we see here. I've already discussed them, so I'm not going to go over them. I've just stuck this slide in here. So you should be able to go through and explain it to yourself. And similarly, we have one for right-sided heart failure, and it's the same thing. So I'm not going to go over them. So now that I've set the stage with heart failure, we're going to go in now. We're not going to go in. We're going to continue by looking at the four components that helps the heart to do its job. We've got blood flow to the heart. We've got the valves that make sure heart blood flow goes in one direction, right? We've got the heart wall, and then we've got the intrinsic conduction system. So we're going to start with what is known as coronary artery disease, or CAD, which is really just the diseases of the heart vasculature. We started off this lecture with a picture that showed the heart and some of the major arteries. And the coronary arteries are the vessels that provides the heart blood supply. So you may have learned in A&P 1105 that even though the heart is so small, it consumes, relative to its size, a huge amount of the blood coming out of the left ventricle. So I think it's about 20% just goes to the heart. So that just goes to show you how much blood it needs, how much oxygenated blood it needs, and how hard it's working. So now that we know that, think about what would happen if the supply, if that oxygenated blood supply is compromised, right? So that is the idea behind coronary artery disease. That's the question we're going to be asking ourselves. What happens when that blood supply is compromised? And we're also going to take a look at some of the things that actually can lead to that blood supply being compromised. Coronary artery disease is also called ischemic heart disease. Ischemic simply means reduced blood flow. You may see it being referred to as myocardial ischemia or coronary heart disease. All refer to disease of the heart vasculature. And what marks CAD or CHD is insufficient delivery of oxygenated blood to the myocardium, ischemia, and the most common cause, right, of cardiac ischemia is atherosclerosis of the coronary arteries. I introduced atherosclerosis in lecture 1. So we talked about just briefly what it is and what are some of the consequences if it happens in the heart, or if it happens in the brain, or if it happens in the periphery. What we're going to take a look at now is we're going to explore atherosclerosis in a little more detail, right? The sequela or the consequences of coronary artery disease, we're going to discuss angina pectoris. Angina pectoris can lead to myocardial infarction. We can have dysrhythmias depending on which artery is blocked. We can have heart failure or sudden cardiac death. And so for coronary artery disease or coronary heart disease, we're going to be in chapter 18 of the text, right? Really, we're just looking at ischemia, a lack of blood flow and reduced oxygen. Usually it's to a different part of the body. In this case, it can be to a different part of the body. In this case, we're just looking at what happens when the heart when the blood flow to the heart is compromised, right? Coronary artery disease, you can have resulting from things like smoking, high blood pressure, high cholesterol is a big one, diabetes. All of these can lead to the blood vessel injury and inflammation, and that can lead to what is known as a plaque buildup. And we'll look briefly at what plaque formation looks like. It's problematic because one of the things it does is that it narrows the size of the lumen of the blood vessel, and so that impedes or even blocks blood flow. And that's what we're going to explore in the next few slides, right? So the cause of coronary artery disease, here I've got coronary artery disease. The most common cause is atherosclerosis. I've put this pie chart here, right? And we're looking at causes of cardiac disease, coronary artery disease. And all I want you to take away from this, we're going to come back to congenital heart disease. We're going to talk about cardiomyopathies. I've talked about hypertension, but really we're not going to talk about it in the context of the heart in any more detail. But look at how much of this pie chart is chewed up by atherosclerosis. And really it's just a disease, we've described this before, where plaques, and these plaques, they are fatty deposits. They tend to build up, if we look here, they tend to build up on the walls of the arteries, narrowing and potentially blocking them, right? And that is the problem, because if it narrows these arteries, right, it leads to ischemia, a reduction in blood flow. You can also have a thrombus forming. Areas that are sort of laden with plaque, they become stiff. They may undergo vasospasm. The endothelial cells may become non-functional. So all sorts of things can happen as a result of these plaque formation. And I've talked about where they tend to be formed. We went over this in the first lecture. So atherosclerosis is the most common cause of coronary artery disease. There are other uncommon causes of ischemia. I've listed them here. Poor perfusion. There's a problem with microcirculation. What is microcirculation? It's the circulation between the arteriole and the veins, so in the capillary beds. So if you've got a problem there, even though the blood flow seems to be normal, the heart will experience ischemia if there's not enough oxygen, if the blood is not properly oxygenated. So if you've got a respiratory disease, so if you've got I don't know, something that prevents you from being properly oxygenated, the heart may experience that as ischemia. But this is where we're going to be focusing our attention. In terms of the risk factors, we're talking about coronary artery disease, but the risk factors for coronary artery disease are essentially the same as the risk factors for atherosclerosis, because atherosclerosis is really the most common cause of coronary artery disease leading to ischemia. All right. We've got non-modifiable and modifiable risk factors. So the non-modifiable ones are the things that we are just born with. We can't change them much as we'd like to, and we just have to live with them and make the best of them. So your age, right? As nobody can sort of slow down their age, even though there's a ton of research and people over there spending millions of dollars trying to slow down the rate of aging. At the end of the day, right, your body is going to be 50 years old if you've lived for 50 years old. You can't sort of reverse that time. Your gender, males tend to have an earlier onset of coronary artery disease. The risk increases in women after menopause. Your family history will contribute to it. So if you shared genetics and you shared some sort of environmental exposure, that can influence whether or not you develop CAD, and your ethnicity, right? Your ethnicity, you see increased incidence of CAD and hypertension among Black Americans, for example, compared to white Americans, right? One of the reasons is that the prevalence of smoking and diabetes and hypertension, for example, is greater among Black Americans and the Black population in general and Hispanics. For white Americans or for Caucasians, really they're more likely to have abnormal serum lipid levels. And so you see there's sort of this difference in terms of your ethnicity. The factors that you can change or that you have control over, right? Dyslipidemia, so your diet comes into play. Whether you do things to prevent hypertension, whether or not you smoke, whether you develop type 2 diabetes and insulin resistance, obesity, sedentary lifestyle, and an atherogenic, a poor diet, so a diet high in fats, for example. Those are all modifiable risk factors. And if you check these boxes, you increase your risk of developing atherosclerosis and by extension, coronary artery disease. So how does atherosclerosis develop? We're just going to go over it lightly. This really is a nice kind of sequence or flow chart that visually depicts what happens and how you go from a seemingly healthy lumen, a seemingly healthy endothelium, to one that's sort of bulging or protruding into the space through which blood flows. Right. It has to start, the process starts with endothelial injury. Endothelial injury usually leads to inflammation. And so the injury can be caused by a number of factors. I've mentioned some, and here are some that we see here. So things like toxins and viruses and hypertension. And that can precipitate endothelial injury. Right? That inflammation and injury can activate monocytes, which triggers, which means an immune response has been activated. And those monocytes can then infiltrate the arterial wall that we see here. And that starts the whole process, because one of the things that it starts to do is to affect the smooth muscle. It causes the smooth muscle to proliferate. As that happens, it changes the nature of the endothelium. They become more leaky, and so you see more cells start to go in and to affect what's happening there. If this individual is dyslipidemic, the lipids starts to deposit on the intima and the inner lining, and before you know it, right? You have these monocytes starting to ingest these lipids and forming foam cells. And eventually what you see are what are called fatty streaks. Fatty streaks actually mark the beginning, right, of the development of an atherosclerotic plaque. And so with time, you get the same process occurring. And at the end of it, you've got sort of this, what is called an advanced plaque. And so within there, you can have inflammatory cells. You can have these foam cells, which are just these huge macrophages that have started to engulf the lipid that's been developed. You might find some cellular debris in there. Sometimes the smooth muscle kind of grow over this lipid core that we see here. And the problem is that this structure starts to bulge out into the lumen of the blood vessel, right? As the size increases, right, it can cause the area around it to become stenotic. It can cause the area within the lumen to be smaller, and that can have a whole bunch of effects, as we will see, on blood supply to the heart. The interesting thing about this is that plaques start to build fairly early in childhood, and by middle age, most people have some degree of atherosclerosis. I know that's a bit scary to think that at this age you're starting to do this. One of the ways you can sort of slow down this process is just by being mindful of what one is consuming in one's diet. Okay, so we start with damaged endothelium. We've got fatty streak and the lipid core formation, and then we've got the plaque with a cap on it. This next slide I'm just going to mention rather quickly is just for you to realize that with time, that plaque can continue to grow. So you can go from a relatively small blockage, and that can increase in size. With the increase in the size of the plaque, right, its effect on blood flow is to reduce blood flow. So as plaque sizes increase, it means that it's bulging more and more into the lumen, and it's reducing blood flow, right? At 75% blockage, that's when you get a significant effect on blood flow. And the thing about it is that these plaques can be found anywhere within the vasculature that supplies the heart. Sometimes what happens is that you can have collateral circulatory routes developing. So you see here, you've got a plaque that's developed, but you've got sprouting or new blood vessels being formed to bypass this plaque, but this is not always the case. Right? So plaques are categorized based on their level of stability, right? And that's important because when we come back to talking about unstable angina and myocardial infarct, the type of plaque that one has within one's vasculature will eventually determine whether or not you may see things like stable angina or whether you might have a myocardial infarct, right? So we've got stable plaques versus vulnerable plaque, right? And it really comes down to what is called the cap of the plaque, what's sitting facing the lumen, right? If you've got a thick fibrous cap as described here, this plaque is fairly stable because it will take a lot for this cap to rupture and reveal what's sitting below, which is what usually triggers a thrombus formation. If you've got an unstable plaque, right, or a vulnerable plaque, it tends to have a huge lipid core. It tends to have a thin cap, right? And so when you have high stress, so if this person is hypertensive and you've got something like high shear stress, this plaque is susceptible to, this cap, is susceptible to rupture, because eventually what happens is that this cap can erode, it can rupture, revealing what's beneath, and that can precipitate the formation of a thrombus or clot. And so you can just imagine the lumen size has already been impeded. If you've got a thrombus form, it will further block that, right? And you can severely compromise blood flow. Okay, so we've talked about the development of the plaque. Now we're going to see how does that lead to ischemia. right? Ischemia or ischemia simply means that oxygen supply is insufficient to meet metabolic needs. So I've labeled this section the economics of supply and demand. If supply is sufficient to meet demand, you're fine. If supply exceeds demand, you're fine, right? If demand exceeds supply, then you've got a problem, right? So we're going to look at how ischemia leads to some of the signs and symptoms of heart problems. So what are we looking at here? We've got a normal artery, right? We've got an artery with sort of a small impingement on the size of the lumen, right? And then we've got an artery here where we've got a plaque, a huge plaque, right? So we really have reduced the size of the lumen in this particular case. And so how does that affect what the heart is doing, right? A couple of things that's going to come into play, right? Supply and demand. What does that mean? Supply enough blood to maintain perfusion as the heart is working. Demand is going to be determined by how much work the heart is doing. Okay? So we've got a normal, healthy heart where there's nothing, there are no plaque formations, the vasculature is normal. So what happens with normal activity? You've got enough of a supply of oxygen to meet that activity. If you increase activity, this is the healthy situation, right? What happens is that the heart responds in kind. It will beat faster, it may dilate wider, and so it gets enough oxygen to meet that increased demand that's being put on it. If that activity stops, then it will revert to this, right? The vasculature may vasoconstrict, and then the blood flow will go back to normal just to meet the needs of normal activity. So this is the healthy case. The heart is able to respond in the healthy sense to an increased workload or an increased demand by pumping or extra blood, right? So what happens then when we start to get issues with plaque buildup, right? In the milder cases, right, when you're at rest or when you're decreased activity, supply is able to meet demand. And again, we've got this teeter-totter, right? We're trying to balance demand with supply, right? So at rest, the heart is fine, right? Increasing exertion, if we look here, increasing exertion, right? In some cases, when we've got atherosclerosis, that may cause the heart some problem because the diseased vessels, I said, is not only narrow, but oftentimes they're stenotic, so they don't dilate very well, right? So when you start to increase activity, that puts extra work on the heart. And because it can't meet the demand, you may start to experience pain because there's not enough blood flow to meet demand. So you've got myocardial ischemia. So you see this sort of seesaw or teeter-totter kind of tips in favor of the individual, which you don't want. You always want the supply to outpace demand. This individual starts to experience pain. It's called angina. We'll look at that in a minute, right? But once that activity stops, right, then the pain goes away and they're able to live, to operate quite normally. So, think of a patient that says, for example, I'm able to, I can walk 4 blocks, but after 4 blocks, I have to stop to catch my breath, right? Or I usually have to rest at least once when I'm halfway up the stairs, right? So in the initial instance, they're fine, but as the demand starts to increase, the heart can't meet the demand, and so you have to sort of slow down, allow the heart to come back to sort of baseline and then start again, right? Stable angina, the pain goes away with rest. You have a problem, right, when even your basic needs causes pain. So when you're at rest and you still can't, the heart still can't meet the basic demands of the body, this is when you have a problem. Right? And this usually happens when there's occlusion of the vessel. It's not only narrowed, but it's occluded. And this is when you see things like myocardial infarct. So all we're thinking about as we go through this is supply and demand. Supply and demand, right? When demand exceeds delivery, ischemia occurs, and this manifests as chest pain. You have angina pectoris. It can be stable, it can be unstable, it can be a myocardial infarct. That's the big take home from this part of the discussion. Right. So what are the critical factors affecting cellular demand for O2? Right. Here again, demand, supply. When it's balanced, we're happy. Right. When demand outpaces supply, there's a problem. Okay. So, what can affect cellular demand? I'm just going to mention this and then we're going to take a little bit of a more detailed look, right? The rate of coronary perfusion. What can affect the rate of coronary perfusion? What do I mean by the rate of coronary perfusion? I mean the rate at which blood flow to the myocardium of the heart is taking place. So remember, the heart doesn't sample the blood in the ventricles. When it pumps out, when the left ventricle undergoes systole and ejects that blood into the aorta, the ascending aorta, the first two arteries that branches off the aorta are the left and right coronary arteries. That's how the heart gets its blood flow. So it takes the first sample of blood to feed, so to speak, the heart so that it can continue to pump. So if you've got plaques, that is going to affect blood supply, right? A thrombus, a vasospasm. What's a vasospasm? A vasospasm is just a constriction of the blood vessels, right? So if the blood vessels vasoconstrict, then it's going to reduce blood flow. That's going to affect the rate of coronary perfusion. Microcirculation or poor perfusion pressure, those can all affect the rate of coronary perfusion, right? That's the supply. That's the supply. So this is what can affect supply. What can affect demand is going to be the myocardial workload, how hard the heart is working, right? So if you increase heart rate, if you increase preload, what's preload is your end diastolic volume. So the bigger your end diastolic volume is, the more your heart has to stretch to accumulate that volume. That's more work for the heart. Increase preload, that's really the backwards pressure on the SL valves. If you increase contractility, that's all increasing the workload of the heart, right? So we've got supply and demand. Those two must always be balanced. Otherwise, we've got ischemia and we've got problems. Right. So I've just stuck this in here and I'm going to, really what I want you to take away from this slide is what can happen as a result of ischemic events. Again, ischemia, a reduce in blood flow and therefore a reduction in the supply of oxygenated blood. Usually what happens as a result of an ischemic event depends on the length of the attack. Right? So if it's less than 20 minutes or if it's greater than 20 minutes, you might have effects on the electrical conduction system that leads to dysrhythmia, which can precipitate sudden death. You may also have issues with pumping that can lead to heart failure. Right? In terms of the range of effects on the myocardiocytes, you can have complete recovery, you can have contractile dysfunction, or you can have myocardial necrosis or cell death. So you can have a range of effects in terms of what's happening on the myocardium. Okay, so what have we talked about so far? We've defined ischemia. We've talked about the importance of blood flow to the heart. We've talked about one major pathology that leads to ischemia in the heart, which is atherosclerosis. How atherosclerosis develops. And so what we're going to look at now, right, is some of the coronary syndromes that can result from ischemia. We're still looking at what happens when there's a disease of the heart vasculature. But we're really going to talk about the different types of diseases or different types of syndromes that can result from that. A syndrome, I think I've mentioned, is just a collection of signs and symptoms. Sometimes they affect more than one organ, but they're classified as a syndrome because they usually occur together in response to a certain condition. Where would I have mentioned syndromes before? I would have talked about metabolic syndrome when we were discussing diabetes, right? So we've got 5 clinical syndromes that can result from coronary artery disease, and the way they're categorized is based on the severity and the onset of symptoms, right? So we've got things like stable angina pectoris and ischemic cardiomyopathy, right? Those are chronic syndromes. Chronic syndrome, just like think of chronic myelogenous leukemia. You would have done neoplasia, or you may have done neoplasia by now, right? It's something that is slow progressing and slow developing, right? Usually you see these two when you've got a stable plaque, right? Then you can have acute syndromes. This is where the problems are, right? Acute syndromes we'll see when there's a change in the morphology of the plaque. Usually what happens is the plaque ruptures. The rupture releases or exposes thrombogenic materials below. You get the formation of a thrombus, and then you've got these life-threatening complete blockage of the artery, right? And the syndromes that develop from that are unstable angina and myocardial infarction, right? And any of these can lead to what is known as sudden cardiac arrest. So we're going to look at angina. We're going to sort of define angina as in a general sense, because really it is the hallmark of coronary artery disease. And then we're going to try to distinguish between stable angina, unstable angina, and myocardial infarction. Okay, so coronary syndromes, right? We are trying to understand, in discussing these syndromes, how the heart adapts to exertion. If it's a healthy heart, it just increases blood flow, right? Blood flow to the heart just increases because it pumps harder, it pumps faster, it dilates its blood vessel. But what happens when someone that is atherosclerotic or they have atherosclerosis and they undergo some sort of exertion? How does the heart adapt to that? The lumen, the size of the lumen is already smaller. Oftentimes in the areas of the plaque, it's stenotic, so it can't dilate to increase blood flow, right? So then what happens in that case, right? And so one of the hallmarks of coronary artery disease, specifically atherosclerosis, is this condition called angina or angina pectoris, right? And I've said here it's the cardinal symptom of coronary artery disease, and you see it or it occurs when the myocardium, so that's the heart muscle itself, become ischemic, right? So I'm just going to give you sort of a brief overview of what angina pectoris is, what causes it, right, and some of the possible consequences, and then we're going to look at specific cases, or different types, I should say, of angina, right? So angina pectoris, right, I've said there it's intermittent chest pain, and sometimes it's described as, what's the word I can use, kind of diffuse pain over the anterior chest wall, right? Some patients have described it as experiencing pressure or a cramp or sort of a crushing sensation. I said they're squeezing, or sometimes a clenched fist that's being poked into your sternum, right? Some of the signs that accompanies this is shortness of breath, The patient may become pale. They may start sweating, because the sympathetic nervous system has been activated. And you may see angina or chest pain being described as referred pain. Why is it called referred pain? The reason is that there are myocardial pain receptors and sensory neurons from areas like the jaw, or the arm, or the neck, or the back, and they travel along the same route. And so because those pains from those areas travel along the same route with as the myocardial pain receptors, that myocardial pain may be perceived as coming from those parts of the body. Sometimes, people are experiencing myocardial pain, and because of the referred pain, they may attribute it to indigestion or dental pain. And so you have to look for the other signs and symptoms that goes with this, because the brain can't tell us if the pain is coming from the heart, or if it's coming from the arm, or if it's coming from the chest, or if it's coming from the neck, right? The brain can't distinguish between those areas, right? Angina pectoris results from an increase in the demand for oxygen by a heart that has atherosclerosis in one area or in some of its vasculature. So because in this case, atherosclerosis, you've got narrowed lumen, blood supplies diminish, then you experience pain. That increase in demand may be from exercise, or they may be from a stress test. They may have increased preload or afterload or heart rate. Again, this comes back to that previous slide. But any increase in demand, and if it can't meet that increase, then you might find that the patient might experience angina pectoris. Right? We'll come back to this, but sometimes that can lead to a problem with the heart pumping, because it needs oxygenated blood to be able to do its work. And so if it doesn't have that enough blood to generate ATP to do its work, then you might have a problem with pumping. The next couple of slides, we're going to look at the patterns of angina pectoris. We've got stable or typical angina pectoris, vasospastic or prismatal, and then unstable or crescendo angina, which is really a myocardial infarct. We're going to start with these two, stable or the classic and the prismatal types of angina, two of the three patterns. So the stable is the most common form, right? And it's the most common form. Usually in this case, the person has some sort of a buildup. It's a fairly stable plaque, and that plaque is impeding the ability of the heart to respond to increased demand. What makes it stable is that it has a predictable onset, right? So whether it's physical or emotional exertion, right? Usually what happens, the pain will come on, the intensity of the pain will stay the same, the pain will last for the same length of time. That pain can be relieved by rest or nitrates such as nitroglycerin that can vasodilate. But once you take the rest, once you stop doing the activity, or once you stop or once you take the nitrates, then that pain subsides. That's why it's called stable. So we know there's a problem. We know what triggers it. We know how to fix it. And so, it's kind of predictable, right? Vasospastic or variant angina is a little bit different, right? This type of angina is unpredictable. It's not related to exertion, whether emotional or physical, but it can occur at night. It can occur at night, but the underlying cause for this increased myocardial demand, because you're not exerting yourself, is unclear. And so what the proposed mechanism now is that the pain that one experiences as variant angina is caused by vasospasming of one or more of the major coronary arteries. And the interesting thing about this, that vasospasming right, may or may not be associated with atherosclerosis. This type of angina may intensify or worsen. It's relieved by calcium blockers. It doesn't respond to rest necessarily. It doesn't respond to nitroglycerin. And so that's how it's kind of different from stable angina pectoris. Okay, so far we've just moved into coronary syndromes after having discussed diseases of the heart, after having introduced diseases of the heart vasculature. The next topic is on stable angina and myocardial infarct. I'm going to stop this recording here, and then when I pick up on the next one, I'll jump into what are called acute coronary syndromes, because I don't want to have to stop sort of in the middle of that topic and take a break and start the next recording. So we started off with heart failure. We talked about left and right-sided heart failure. I mentioned the fact that the failure of one side can lead to the failure of the other side. There are issues with the backing up of blood. There's also issue with the forward flow of blood. Left and right-sided heart failures, while they have some things in common, there are specific signs that are associated with right-sided heart failure. For example, jugular vein distension is one of it. And then there are specific signs that are associated with left-sided heart failure. And then from that, we've just started talking about diseases of the heart vasculature, right? And we've just introduced coronary syndrome. So when I pick up in the next recording, I will finish off diseases of heart vasculature. Then we will turn our attention to valve disease. We will talk about diseases of the heart muscle and the electrical system of the heart. So see you on the next one.